Sure. So we have a case that was put together by our senior orthoptic student, Jill Catton. So I'm just going to turn it over to Katie here, and there are some videos involved.
Yeah. Katie, am I still, I'm not muted. I'm going to ask, rather than have you replay the video, I'm going to say, for everybody's knowledge, I got to see these videos ahead of time, which was very helpful. One of them is longer than the other. They weren't named. I don't know which is which, but on the shorter one is a patient with aberrant regeneration. The very first few seconds, it's very fleeting, but I want people to look before I think the moderator tells her now look straight ahead. Just before that, you'll see the right eye, the eye with the aberrant regeneration, make a couple of big up and down movements without a change in the horizontal position in the other eye. There's a hint of a little up and down attempt in the other eye. So she's -4 at elevation and depression. But I think that's important as far as determining what's going on with the downshoot. So I thought I'd say that ahead of time so I don't say replay the video. People look at it when you play it, and go ahead with your presentation and be happy to have you go.
All right. Maybe I will get Jill to come on the call and just do a quick, very brief introduction of the patient for the folks who aren't familiar with the presentation of the patient. And then Jill, I'll get that short video queued up that Dr. Kushner was just referencing. And then perhaps you can just outline the specific kind of question that you had regarding this patient. Does that work for you?
Yep.
All right. Jill, are you there?
Hi, yeah, I'm here. So we had seen this patient back in August, and we'd been seeing her at the eye center for a couple of years. She's 68 years old, and she has bilateral internal carotid artery aneurysms and bilateral cavernous sinus syndrome. And so at the worst of it, we thought that she had in her right eye a partial cranial nerve 3 palsy with some possible sympathetic pupil involvement, as well as a complete cranial nerve 6 palsy and a partial cranial nerve 4 palsy. And then in her left eye, she had a complete cranial nerve 3 palsy with parasympathetic and sympathetic pupil and lid involvement, a complete cranial nerve 4 palsy, a partial 6 palsy, and then also some cranial nerve 5 involvement. And so in our most recent exams, she had shown some signs of improvement, but we had also seen some signs of aberrant regeneration. So you'll see this on the videos, specifically in the right eye, like Dr. Kushner had said. You'll see the right lid retract on right eye adduction. But then we also saw some weird movements of the right eye. When the right eye moves into abduction, we see that it also depresses, and there's also a little bit of intorsion as well. And we can't really fully explain this movement. On first guess, we thought maybe there was some further aberrant regeneration happening with the 6th nerve to the 4th nerve, but it seems pretty unlikely that that is the reason for the movement. So we thought we would get a second opinion and see what other people thought that was going on with her weird movements.
Can I just a question, if I may, Jill? I'm not questioning the diagnosis, but how did you diagnose a 4th nerve palsy in the face of almost no elevation or depression? What were the criteria that made that diagnosis? I think she may have it. I'm not questioning it. I just wondering how that diagnosis is made.
I think that had been made previously to me seeing her. And I think she had significant limitation of depression just in the area of the superior oblique on her movements.
Okay. Okay, let's do the videos.
Okay, so Katie, can you bring up those videos for us?
Yeah, I'm just going to get them up for you right now.
Those were the movements I was talking about.
You have to hook up your phone. Sometimes it does. I don't know that. Just have some patience. You know, like I'm explaining to you, like that lady.
Shall I be starting to talk? Are we going to see the other video? I don't know if it's necessary. It shows pretty much the same thing.
Yeah, I don't need to show the
Okay.
other video if you want to just talk about that one.
I have so there's some very interesting eye movements, and I feel sorry for this woman. I have several thoughts. First, of course, you have to determine what is your goal. Is she a diplopic patient that's hoping to have single binocular vision? Are we talking about just wanting to have her look better? If it's really a diplopia situation, she has almost no vertical movement in the left eye, and that's her fixing eye. And it's virtually impossible to give someone functional single binocular vision when they have very limited movement in what is their fixing eye. But she could probably be gotten better cosmetically. Unfortunately, both of the videos don't show her in down gaze. I'm going to say what I'm saying, assuming that the down gaze, but I have the versions, and it's -4 in the left eye and limited, but not nearly as much so in the right eye. I'll assume the down gaze video would show the same thing. The important thing to sort out is what's causing this downshoot in the right eye on attempted abduction. Is it air barrier regeneration as was stated as a possibility between lateral rectus? I think that's possible, but I think neuroanatomically that's probably unlikely. I think there's a much better reason to think that this is fixation duress because of what's going on in the left eye. So the left eye has almost no movement up and down. And if we accept the fact, this is why I asked the question, if we accept the fact that she has a superior oblique palsy in that eye, when she looks into a deduction with that eye, all else being equal, superior oblique palsy, the eye would go up, but it's her fixing eye, so she innervates depression to keep the eye in primary. She's very limited in her vertical movement, so you see a large overshoot or secondary deviation in the other eye. Now, One of the things that makes me think this is probably the case is what I said earlier, that very first few seconds, the right eye was really going up and down kind of wildly, where the left eye wasn't moving further into adduction at all. If anything, I can talk myself into it attempts at little vertical movements. One way you could, well, there are two ways you could tell, the easy way and the hard way. If I were caring for the patient, I'd probably get dynamic MR imaging, where I can look at what the muscles are doing in different fields of gaze. If you don't have you don't want to use that test on the first patient you want it on. There's a learning curve, both for your radiologists, for yourself. But once you've got the techniques down and experience with it, it can tell what's contracting when she looks over there. It can tell, is the superior oblique on the left eye atrophic? That you don't need anything special to be able to tell. But I think an easier way that might help you is to have her just cover the left eye, not following something with the right eye, just say, look to the right. And if she tries to look to the right and the eye downshoots, it's not fixation duress from this side. It's some weird aberrant innervation here. But if she can look to the right without that downshoot, then we know it's fixation duress coming from this side. So that's how I would assess her. As far as what to do, as I said, you're limited as to what you're going to be able to accomplish. The main thing is the esotropia and that downshoot. If what I just described, having her cover the other eye and look to the side, no downshoot, that means it's being driven by the superior oblique palsy in the other eye, and she's trying to bring the eye down to midline. I would have the surgery involve weakening the inferior oblique or doing something for even though you don't see a big vertical, it's innervationally happening where she's trying to compensate for it. But you're dealing with a lateral rectus paralysis in the other eye, you know, whatever your favorite procedure is. You could do what's gaining popularity now, just in the last few years, is the Nishida procedure, which it's kind of like the Jensen, but you don't split the muscles, where you just put a suture in the superior rectus, temporal border, lateral rectus superior border, and without disinserting the muscles, just anastomose, tie the bellies together, and the same with the inferior. You may want to be influenced by, do a little better assessment of what the inferior rectus function is in that eye. As I said, I didn't see down gaze, so I can't say, but according to the versions, it's limited about the same as up gaze in the right eye. So I think you could do a symmetric, you could do both superior and inferior muscles. If you like doing just the superior rectus transposition, I never understood why that should work, but it appears to work with Foster augmentation, you could do that. But I think I would basically, after I've sorted out the diagnostics that I said, I would treat it like however you like to treat a lateral rectus paresis of this amount. The lids, I just hold off and see what happens. She has aberrant innervation where the right lid goes up on left gaze. It also elevates on up gaze. So there may be things you can do innervationally to take advantage of that, but I think I'd wait and see what happens after the strabismus surgery. And those are my thoughts. A very challenging case.
Thanks, Jill. And thanks, Dr. Kushner. Jill, do you have any other questions before we move on?
No, I think that answers most of them. Thank you so much.
Great. Anybody else from the audience have a question regarding this case before we move to the next? Okay.
How many more cases are there, Katie?
Well, Dr. Araguntla, one of our physicians from our department has something that she'd like to discuss with you. I'm not sure. Are you ready, Dr. Araguntla, to discuss this case?
Hi. Unfortunately, the USB is showing file corrupted, so I'm trying to remember I told you the videos were quite large, so I had tried to save a version without any videos, and that's what I'm trying to open, but I just have the one case with all the photos and videos. The others, I don't have the videos yet. So if anybody has another case, they can go ahead. Otherwise, I'll just try and maybe present this without a video. Does anybody have other cases?
Not that I'm
Why
aware
don't
of.
you present it without the video and we'll see how we can do.
Okay, I'm just trying to do it off a USB, so just give me 2 minutes.
Can I ask a quick question as we wait for Dr. Araguntla to open her case? Dr. Kushner?
Yes?
My question is regarding accommodative ET with convergence access. So if you plan surgery on the medial recti and you are fully recess them and still there is residual esotropia, what would you do for that?
So the question is, I understand that convergence excess or high ACA ESO, I did the medial rectus muscles and I have a residual deviation. Is that the question? Well, I think it depends a little on age of the patient and how much I did. You know, the younger the patient, perhaps there's a limit to how much. If I'm usually having to do large amounts of surgery on high ACA patients because, you know, the neurodiviations are often big. If I've done anything near what I think is the maximum, I'll just resect the laterals according to, or plicate according to my usual formula. If I've done smaller amounts of surgery, I may re-recess the medial rectus. It depends specifically on the measurements and the amount that was done, but there's no one set formula.
Thank you.
Okay.
Hello, can you hear me?
Yes.
Can you see my screen?
Yes.
What do you see on the screen? Because I can't see what I'm seeing. Sorry.
Well, I see what is slide number 11. It's not in the PowerPoint show mode. So I see all thumbnails of slides 8 to 12 on the side. And I see there's someone holding the child's head. Okay. So if you start the show, now we'll see. Okay.
Is that better?
Yep, good.
Thank you. So this is just a case of a complex strabismus. And Lindsay is an orthoptist who helped me put together the videos and the photos, but there's other orthoptists, Mike, Heather, who've all helped with this case. So this is a patient that I saw when she presented at 3 months of age. Her pregnancy was uneventful. The mother's, there was no exposure to alcohol or smoking or any substance abuse. Birth was uneventful. There was no use of forceps or vacuum or anything like that. Otherwise, a healthy child. Family ocular history was significant only for one first cousin who had strabismus, but never ended up needing surgery. On examination, the child had a large esotropia and was cross-fixating. There was no obvious amblyopia. The eye movements showed an abduction deficit of we could say -5. It was not going past midline. The baby was cross-fixating, and we couldn't really measure the angle. Intraocular pressure was within normal limits. Cycloplegic retinoscopy showed hyperopia around 2.25 with a small amount of astigmatism. And at this point, I was thinking that it's probably a lateral rectus palsy versus congenital esotropia. The fundus was healthy. I didn't see any papilledema or any signs of, increased intracranial pressure, and that I don't have the fundus photo here. So this photograph here was taken in the clinic. Are you able to see it?
Mm-hmm. Yes.
Yeah, so the baby is looking at a light up close in the picture to the top right, top left. And in the other one, the baby's trying to look a little further away. All you can see is those light reflexes, and you can tell that she's has a large angle esotropia. So I made a diagnosis of bilateral abduction deficit with large angle esotropia, started the baby on patching. Even though the cycloplegic refraction just showed about 2.25 hyperopia with mild astigmatism, I decided to do a trial of glasses while we were waiting. And I decided to get an MRI of the brain and orbits. This took a few months, but fortunately, it was reported normal. This was also the time when COVID was starting. There was COVID lockdowns and all of that going on, a lot of uncertainty and protocols shifting by the day in the health region. So eventually I did get her into surgery. I had discussed Botox with the parents, but because they would need anesthesia anyway, and because all this COVID thing going on, and uncertainty as to when she would get in again, I just decided I'll do straight away surgery in the first OR that I got. So I did forced suction testing, and there was no significant restriction to movement, no contracture developed by then. I did recessions of the medial rectus on both sides, 6 millimeters, and kept following the baby. 3 months post-op, we were able to measure residual esotropia, which was about 25 to 30 prism diopters for distance and near. So I waited a few months. We kept doing the patching and working on the glasses, but the esotropia remained, and then I was able to get her in for a second OR date. And during the second surgery, I did forced suction testing again. And again, there was no restriction to movement. I didn't note any sort of contracture, anything. I explored the previously operated medial recti. So my approach to sort of re-ops starts off with sort of forced suction testing. Is there any limitation or not? And then kind of go along with that. So when I explored the previous medial recti, I found that they were about 11 to 12 millimeters from the limbus, which was where I had placed them originally. I debated whether I should further recess them, but I didn't want to place them behind the equator and cause further adduction deficit. So then I decided to do resections of the lateral rectus, and I thought I would do a resection. As I was operating, I noticed the muscle was very atrophic. One of the residents was assisting, and he's here. It was a very thin-looking atrophic kind of muscle, and I just got to sort of feel like it's different. Why not I send it for pathology? It's not my routine, practice, unless we're suspecting cancer or those kind of patients. So I did send this for pathology. I resected 5.5 millimeters, In the past, I've had to do 1 or 2 cases like this, and those were adult patients, and they would always say insufficient sample and shriveled up piece of muscle and all that. So I was very careful to try and, you know, preserve the integrity of the muscle as much as possible and put it in the solution right away so it's not shriveled up. The report came back as fibroconnective tissue and tendon, and that they couldn't really find much of skeletal muscle. So I called the pathologist and I asked, and I explained what the situation is, and that, you know, this is an eyeball of a small child. By this time, she just turned 3. And he said, can you give me more sample? Can you go back and give me more muscle? I said, no, I can't just go and do more resection like that. We have certain criteria, certain tables we follow. This is it. And he said, if you really want, I could do deeper sections to look for skeletal muscle. So this is a picture taken for 5 months post-op after her second strabismus surgery. One of the other things I should mention is, so between the first and second surgery, I kept checking her. I repeat my cycloplegic refraction usually like 4 or 5 months after each surgery. Her astigmatism was increasing a bit, but the hyperopia still remained the same. So here she's in her glasses and she's looking straight ahead. Cosmetically looks good, looking for the distance. And when she's looking up close, you can see that there's not much, there is some convergence, but she wasn't able to do much adduction. And here we're trying to actually use the doll's head maneuver. And interestingly, I'll talk about the movements in a second, but I just wanted to say that by this time it was clear that there was more visual deficit in the left eye, so amblyopia, and she was patching her right eye. That's the cycloplegic refraction. Like I said, hyperopia remained low, but the astigmatism was increasing for some reason. There was no inferior oblique overaction or anything like that. Horizontal movements, there was absolutely none. It was shocking. There's no movement, even with effort, no saccades, no horizontal pursuits, nothing elicited on OKN, not even with VOR. When the pupils were being tested, some convergence was noted and both eyes would converge simultaneously. Vertical saccades were, however, present. OKN was hard, maybe a few beats, but vertically, she's able to move her eyes. This is where the video is, and I'll just pray that it works. It's working for me. Are you guys able to see it?
It stopped, but I could see it.
Sorry, I can't control the audio. It's just,
Okay.
yeah, I'll go back. Okay, there we go.
Yeah.
I'm trying to advance to the next slide. Okay, so what started as possible congenital esotropia, then I thought, maybe bilateral rectus palsy. Now looks like horizontal gaze palsy. There's been no sort of retraction, no upshoots, downshoots, nothing else. So I'm at a loss now. Should I repeat the MRI? We had done MRI prior to the first surgery. That was reported normal. Repeat it and tell them to look more closely, or even go back to the old MRI images and look more closely at the midbrain and pons, or why I actually thought I would send it to pathology was I thought maybe there was some kind of muscular dystrophy at that time when I did the surgery. But then I'm thinking that if it was muscular dystrophy, it's very unlikely to be just that one, lateral rectus muscle of each eye isolated. She's been otherwise healthy, no problems with, swallowing or dysphagia or anything. Her other muscles are fine. She's running. Her gross and fine motor movements are great. Genetics, why I threw that in there is I have 2 sets of patients with horizontal gaze palsy. One is a girl who had presented by, I think, 6 months of age, and her MRI showed changes in the brain, and it was in keeping with what's known as horizontal gaze palsy with progressive scoliosis. So that evolved over time, and I had presented her at one of the conferences, and I met Dr. Engel from Boston, and we had sent, the family was very proactive, very good family. They gave consent, and then the blood was sent to Boston, and they did find the gene for, but that was a different entity, which was horizontal gaze palsy progressive scoliosis. The other family I have is a family that lives in a colony. They shun technology. They usually, they marry within their colony. There's a huge sort of autosomal recessively dense genetic pool. And so autosomal recessive disorders are more common in them. Of the 3 sisters, one has the full gaze palsy and the other has, I think, also some amount of gaze palsy, which is evolving. She was a baby when we just saw her. And the other one has strabismus, something like that. So that's why I threw the genetics in there. If anybody has any other ideas, let me know. Thank you.
So I think that the issues, you ask yourself, what is it that you're wanting to accomplish? I think that from the strabismus point of view, I wouldn't do anything different. She's got a whole life ahead of her. She clearly has abnormal, unknown types of abnormalities with respect to her eye muscles. She's probably not going to stay stable. I think she looks acceptable right now. I don't think, I think perfect is the enemy of good. I think your result is good. With respect to MRI, you have to determine what is it you're looking for. When you had the original MRI, were the radiologists asked to look for the lateral rectus nerve, the nucleus, or were they just looking to rule out tumors and hydrocephalus? Because unless radiologists know what we're really looking for, the answers to what you're asking may be on the MRI that was already done. I don't consider myself expert in the diagnostic medical workup of patients like this. I personally, if she were my patient, I would have genetics see her. You might talk to Elizabeth Engel about it. You obviously have a relationship with her. You did with the other patient, but yeah, she has a gaze palsy. Pathology of the extraocular muscles is very tricky, and they to interpret. And the lateral rectus, I've certainly seen resected sections that just come back fibrous tissue. I wouldn't explore that further unless you identified a genetic defect for which something like that is in order. These are patients that unless she fits into a specific genetic or neurologic pattern, we're not going to have a specific diagnosis for her. But the important thing is I think you have a good result as far as for strabismus, or as good as you're going to get at this age, and I wouldn't do anything different.